Good morning for some, good afternoon for others, and welcome to our INTAC Training Academy session today, which will focus on understanding and identifying trauma response in self and others. Welcome. Next slide, please. This program is being brought to you through INTACT, and the transformation team that is supporting this work is community wellness and peer support. And this is one of our signature programs, which is called the Training Academy. Next slide. And before we jump into the training today, I'll just go over a few slides and then we will jump right in. First, I'd like to make a disclaimer that this presentation was prepared for INTAC under cooperative agreement with SAMHSA, and all material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. And again, this event is sponsored and supported by SAMHSA of the U.S. Department of Health and Human Services as part of a financial assistance award over 5 years, and with 100% support funded through SAMHSA and HHS. Next slide. In case of any security issues that may occur, this session will immediately end and will not resume using the same link, but you all will be sent a separate email with a link that you can, with further instructions. Next slide. We would love to share some of our awesome partners who are joining us in doing this work, and they're all listed here, and they all, play a role in making sure that we're able to continue to bring these wonderful programs and trainings to you all. So just wanted to highlight our partners. Next slide. And then we just want to share our vision and services. At INTAC, we believe that all children, youth, and families living with and impacted by mental health challenges will have access to the resources and opportunities they need to thrive in a comprehensive and equitable system of care. And this is our model here. You can take a look at it. Okay, next slide. Thank you. All right, some commonly asked questions. So please please look out for a follow-up email after today's session. And in that email, you'll find really important information regarding the receipt of a certificate of completion for today's training. You'll get a copy of that presentation as well as a copy of the recording. So all of that will be provided to you after today's session. Next slide. And very, very important for us to continue to bring these important trainings to you is the completion of our evaluation survey. And once you complete the survey, you'll be redirected to the CE hours form where you will receive your CEs for attending this training. And all of that information will be sent to you again after today's session. Next slide. So we have a Q&A feature on our platform today. So we ask that if you have a question, please type it using the Q&A feature as opposed to using the chat. The chat can get really full with comments and things like that, and we don't want to lose any of your questions. So please, please, please use the Q&A feature for any questions that you may have, and we can use the chat feature for everything else. Just wanted to bring that to your attention. Next slide. Okay, and before I reintroduce the session again, just want to make everyone aware that we do have ASL interpreting services available for you today, and you should be able to access that also through our platform. So again, welcome to today's session. I am Dr. Dion Coker-Apia, and I will serve as the moderator for today's session, Understanding and Identifying Trauma Response in Self and Others. And I'm happy, next slide, happy to introduce our trainer for today, Dr. Denisha Carter, and I will read a portion of her very long bio. She's done such great work, but I want to give you an introduction to who she is, and then I'll turn it over to you, Dr. Carter. Dr. Denisha Carter is a licensed clinical psychologist and assistant professor of clinical psychiatry at MedStar Georgetown University Hospital in the Department of Psychiatry, Child and Adolescent Psychiatry Division. As the director of clinical training for the Department's Psychology and Social Work Training Program, Dr. Carter's work focuses on the development, supervision, and implementation of a holistic externship experience for third and fourth year doctoral level trainees and internship for first and second year master's level social work trainees. As a member of MedStar's Center for Wellness in School Environments, also known as the Y Center, Dr. Carter provides administrative consultation to leaders and therapy to children, families, and educators within schools throughout the district. In addition to her role at MedStar Georgetown, Dr. Carter is a member of the DC Mental Health Stakeholder Learning Community and the DC School-Based Behavioral Consortium. She is nationally certified in trauma-focused cognitive behavioral therapy and evidence-based treatment for children and adolescents experiencing challenges as a result of experiencing and or witnessing a traumatic event or events, as well as certified juvenile sexual offending counselor. So with that, Dr. Carter, I will turn it over to you and excited to moderate your session today.
Good morning, everyone. Good morning or good afternoon, everyone. I'm excited to be here with you today to share with you some information on trauma and adverse childhood experiences. And so what the first thing that I would like to say is that as a presenter, I don't want to just talk to you all. Would love your engagement. Please use the Q&A feature, as Dr. Coker-Pia mentioned. And just we'll have time, of course, for questions, but please feel free to jump in and share any questions that you have throughout, as well as to share any experiences that you've had professionally in your work. So I like to start off presentations when we're focusing on topics such as trauma with a space of recognition that this is sensitive content. And so as we're discussing a number of things today and doing some exercises together to build our knowledge, there may be some uncomfortable feelings that come up. And so some of this content can be activating to individuals. And so if you feel you feel those uncomfortable feelings or feel activated, please take care of yourself throughout these 2 hours that we have with each other today. So it is okay if you need to have a pen and a piece of paper in front of you to take a moment to distract your brain and doodle a bit, or to excuse yourself from the space for a moment. Please just take care of you throughout this time today. Okay, so just a few learning objectives. We're going to introduce the concept of trauma, and then talk a little bit about adverse childhood experiences, and then identify the trauma response through the use of observation and screening tools. And then also to focus and increase your understanding on secondary traumatic stress and vicarious trauma and other related topics. So we're going to start off with a little activity. For the next few items, I'm going to ask you to really focus on your own genuine opinions. And this is something, so I'm going to take a pause here and ask folks to either grab their phones and open the notes section in your phone, or to grab a piece of paper and something to write with, um, to do this next activity. So I'll take a 10-second pause here. Okay. So again, this is not like how you would be based on your experiences or your role. This is not focused on how you would expect, you would be expected to respond. I want you to give your honest opinions. This is a reflection activity for yourself. So we have 5 questions here, or 5 statements here on the screen. On the items below, please select a response ranging from 1 being strongly agree to, disagree, 1 being strongly disagree, to 7 being strongly agree. And so let's take about a minute and a half to just write down your responses to this in your notes section or using your paper in front of you. Okay, so so we I would love to hear, let me just jump back for a second. If folks feel comfortable, I would love to hear any thoughts here. So this is an exercise that we're doing to as kind of a personal reflection and self-assessment of your knowledge related to trauma. Um, so what are some thoughts that we have here? Were any of these statements a bit like, I never thought about it this way, or um, I think I do have a little bit more knowledge than I may think going into this topic. Dr. Coker-Pia, do we have any responses there in the chat?
We just have attendees listing their numbers. Let's see what we have here. I see DeAndre Gardner shared that trauma, as I've learned it, is to be specific to the individual, which is true. All can be 7 depending on who it's impacting. Rebecca. Um, let's see. And Casey Park had a comment that it's hard to find resources that focus so much on non-occupational secondary trauma, and she's excited. Casey is excited for this. Question number 4, maybe you want to respond to that. For question number 4, I've never thought about that. That's what Kaya, I hope I said, pronounced her name correctly, the name correctly. And then Danita shared that the idea of permanent damage to someone vulnerable gave them something to think about further. This concept of permanent damage. And then Stacy shared that I think trauma is specific to each individual, and realizing that external and internal factors impact each person differently, but can always be a 7 depending on those factors. So some pretty good comments here. Anything can be a trigger.
Mhm.
depending on the situation. And there's another comment about number four, and particularly about the word permanently. So I don't know if you want to respond to that. Let me see if there's
Ab-
anything else. Go ahead.
Absolutely, absolutely. Four is the typically is the point or the question, the statement that receives the most like hmm
Mm-hmm.
from folks. And we're going to talk about this a little bit more. But the idea here is that when an individual potentially has already been exposed to a traumatic event, that this could be a point of additional exposure. And so this is where we'll get into the space. We'll talk a little bit about the how if even when an individual has experienced the trauma, how there are environmental factors that can be triggering.
Mm-hmm. Okay.
Absolutely.
That
Thank you,
makes
Dr.
sense.
Fabricia.
Of course, of course.
Okay, so let's step into defining trauma. And so trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. And so this is a universally used definition for trauma. This comes from SAMHSA, who and SAMHSA's done a lot of research over the years in relation to trauma. But we see variations of the definition of trauma, and oftentimes the variations depend on population and other factors. And so, watch just this quick. It's about a minute or so video. Please let me know. Please let us know in the chat if you're unable to hear this.
Trauma. Trauma is defined as a deeply distressing or disturbing experience. These can include many different things for a child: moving to a new place, death of a loved one, changes in routine, injury, seeing violence, experiencing abuse,
We can't see the video.
natural disasters.
Let's pause here for a second. Let's see.
Does the video have a
etc.
closed caption?
These intent. What is trauma?
Pause here, and I can click on the caption there.
Thank you.
Trauma is defined as a deeply distressing or disturbing experience. These can include many different things.
I think I have an overlap here. I apologize.
These can include many different things for a child: to a new place, death of a loved one, changes in routine, injury, seeing violence, experiencing abuse, neglect, bullying, natural disasters, etc. These intense events affect the child's sense of safety and well-being. In many ways, the child becomes stuck, and they relive the trauma again and again, and it becomes more difficult to deal with over time. The problem lies in their inability to cope. It's important to understand that traumatic events happen to everyone. The difference here is how someone deals with an experience. When trauma interferes with everyday life and becomes a problem for your child, it is best to get assistance from a mental health professional. These may include post-traumatic stress disorder, acute stress disorder, adjustment disorder, reactive attachment disorder, etc. Your mental health professional will be able to help determine if your child has trauma, what kind, and how to treat it. If you suspect your child is experiencing trauma, it is best to seek help as soon as possible. Early treatment is one of the most effective ways to help a child learn coping skills to deal with their trauma. So, how do you know if your child has trauma? You will notice distinct changes in the mood, attitude, and behavior of your child. They will feel unsafe. They may have difficulty forming attachments, lack impulse control, have trust issues, cannot control their emotions, have low self-esteem, and even have thoughts of suicide. Your child may be fixated on an event or events that were the cause of these changes. Again, Early treatment is recommended, and it may include medication and therapy. Therapy will help them work through the traumatic event. Medication may be needed to help regulate their moods. Using
Okay, I'm going to pause here. Because we're going to talk a little bit about some of these, some of the things that were shared in a bit more detail. Okay. So when we think about different types of trauma, we're going to talk a little bit in a moment about different types when we're thinking of abuse and neglect, different types of abuse, different types of neglect. But more specifically, we're thinking about primary and secondary trauma. And so primary trauma is when an individual has personally experienced that trauma. And so, for instance, when a child has been physically abused by a caregiver, that child is experiencing direct trauma. Well, versus with secondary trauma, the individual may not have physically experienced or even witnessed the event, but they're experiencing a psychological impact. So, for instance, I see this in children who have a very good friend who is being physically abused by a parent, and that very good friend is sharing with them the experiences that they're having in their home and is potentially asking them not to tell someone. And so then a parent will say, well, my child is, all of a sudden, they're not eating dinner. They're refusing to eat dinner. They are spending a lot of time in their room. But that particular child B, is not the child who is directly experiencing the trauma. So they're experiencing secondary trauma, that indirect trauma. Acute is an exposure to a single event that might last for a limited period of time. So, for instance, this may be the child who goes to visit their dad during the summer and is physically or is sexually assaulted by a family member during that week when visiting their dad. It was a single incident, and at the end of that week, the child returns to their primary caregiver, who is their mom. Where with chronic, this is experiencing multiple traumatic events over a longer period of time. So if we use that same example, this may be the child who goes to visit their dad for 2 months during the summer and every major holiday. And so that child may be exposed to this family member who is sexually abusing them every time they are with their dad for this extended period of time. And it's happening multiple times during, for instance, that 2 months that they're there during the summer. So that's the chronic. And then we have complex trauma, and complex trauma is repeated and ongoing, and oftentimes more quite frequent. And so complex trauma is looking at a particular set of, we're looking at the experience, but also a particular set of symptoms that occur as a result of multiple events. And those events may include the same type of abuse. So it may include multiple events of sexual abuse, or it may include an event of sexual abuse, events of emotional abuse and physical abuse that can result in complex trauma. And so complex trauma impacts personal relationships for children, as well as adults, can impact physical health. And if we're also, like I said, if we're speaking of adults, it can also impact the work life. Another point I want to make here is when we're thinking about complex trauma, we're thinking also about single incidents as well versus complex. And so a single incident may have a clear beginning and an end, Also, some single incidents are public events. So we may have, for instance, a natural disaster. Um, and so versus complex trauma is more likely to begin in childhood or in early adolescence. And so with complex trauma potentially beginning in childhood and early adolescence, it can have a pretty significant impact on development. And so then you may have an individual who is an adult who begin experiencing complex trauma in their childhood, and it has impacted their brain development. It has impacted their body. It's impacted their health, and we're going to talk a little bit more about the health piece as well. And then there's a component here also of when trauma occurs in childhood and even younger ages of childhood, there's also this potential experience of attachment trauma. And so very quickly in the space of attachment trauma, you may have a mom and a dad who's raising a child in the home. And maybe there was domestic violence that occurred in the home. And the child witnessed dad physically abuse mom. And so maybe, for instance, maybe dad is eventually arrested and is no longer in the home. But after time, dad is trying to re-engage with the child. But the child is, because maybe the abuse started fairly early. And now there's a break in that attachment bond that might have been created in the early years. But there's a break in that attachment bond. And that can also then lead to the child being more attached to the mom and attached in a way that is unhealthy. So here's another quick activity for us to do together. On that same piece of paper in your notes section, let's just take 60 seconds and identify 3 wishes that you have for your present life. Would anyone like to share a wish that they have? Would anyone like to share that verbally or in the chat?
Certainly, I'll be bold enough, Edward Barnett. And clearly, with me and with my age, I've been married 38 years, and my wife is going through some challenges now. So, my wish would be that she was doing better, feeling better. So, that's my concern.
Thank you for sharing that, Edward. Thank you. Would anyone else like to follow suit?
I would like to share, like, working with children. Can you hear me?
I can.
Yeah. It's like, my grandchildren, I take care of 7 of them. And when I think about like what all they're going through and stuff like that, even in school, it's like I want to better myself as a grandmother, and I want to learn more about, I raised 13 children, but it's like it's different. And your grandchildren are going through stuff, and all this stuff that is like so far is very interesting because I'm not trying to sit there and judge my grandchildren or nothing like that. But um, when you talk about trauma and stuff like that, I know they have experienced some of that, and it's like I tried hard to talk to my daughter because she was in a relationship where she was getting beat up in front of the kids, where they were seeing it and they were telling, where DSS got involved. That's how I got them because I didn't want my kids to be locked up in the DSS program. But anyway, learning how somebody what the kids are going through in school. I have 3 grandchildren and are going through a lot because their mom and dad, one of my other daughters got divorced from her husband, and they're going through a lot right now. And my daughter's kind of neglected them right now. I feel like they're going through have abandonment issues because she's like more or less taking care of herself and not worried about the children, what they're going through. But when they're around together, whatever they argue and they fight, and she gets mad and it's like I was telling her, you don't need to get mad at them. Just listen. They're going through the same thing you are, but they're children. You got to remember that. So it's kind of hard to really explain to your own children without them getting mad. And then when I suggest them to talk to somebody like, that I think that's going to help them, it's like they get really like, stop trying to run our lives, stop doing this. So I know I'm hitting something, but it's like with my grandchildren, it's like I just try to find ways to sit down and talk to them and just listen. And then um, I'll share stories about when my childhood, and they can't believe I went through this and that. But, at the moment, just what they're going through, I kind of share that because, my mom and dad got divorced too and whatever. But I didn't have a real bad issue with that because our dad was hardly ever home with us. But when my one sister did, and she used to cry and all the time when he was gone, it was kind of his favorite, and he showed it. But anyway, so my three rich to identify 3 riches that you have for your present life is like just to work with my grandchildren and help them through whatever they need to go. I mean, and able to just talk with them. And it's like sometimes I get overwhelmed as a grandmother because they're not my children. It's hard to try to really correct them in ways like I don't believe in hitting. I don't want to be abusive. I don't want my kid. I'm glad my girls and sons aren't abusive like that to their children. They may get mad and holler, but I told them that's a sign of abuse too. And they said, "Well, I'm not hitting them."
Yeah,
Yeah.
I think, one of the great things that you are doing, that you can do and that you are doing is you're creating a space for your grandchildren to feel seen and be heard. Um, when I work with children, one of the things that oftentimes comes up, especially children who experience trauma, and have witnessed a number of things in their home, it is that they feel invisible. And so that is a very important thing that you're doing right there. So I'm going to ask others to share in the chat, in essence of time. But thank you for doing this activity. One of the reasons, so this is an activity that we do sometimes in trauma-based treatment, because individuals who have experienced trauma and those who are part of their support system um, find it challenging to see the like the support that's being provided, but to also see opportunities to move forward. And so this is a nice space of just like reflecting and even grounding a little bit. So thank you for participating. So we'll just share a little quick video here concerning the barriers of treatment.
The number one thing for trying to engage economically disadvantaged folks in therapy is making sure that you make room for that in the therapeutic work. So talking about what impact the economic disadvantage has on their mental health, has on their ability to come to therapy, not kind of taking that off the table, but actually addressing that. And then also providing those resources that will make it easier for them to get to therapy. So is there a way that we can provide childcare, or are there travel vouchers that we can provide, or can we reimburse for taxis if that's what they have to take to get to therapy? So speaking to some of those basic needs, because we can't really focus on our psychological health if some of our just most basic needs are not being met. I think trauma impacts individuals, but then it also impacts the way the individuals interact in their social networks and their social systems. And so it's really important for us to educate communities about trauma and the impact of trauma on folks' lives and how to support people. Disclosure, we have tons of research showing that the response that you get when you disclose your traumatic experience has tons of impacts on your later mental health. We're talking about people who are economically disadvantaged. So you think about folks who may not have a lot of work flexibility, and you think about when we tend to offer mental health services, it's during the work hours. And so that's a challenge. There's also transportation issues. Sometimes our places where we offer psychological services are not accessible by public transportation, or you may find that a whole household of 5 is sharing one car and they have competing demands on when they need to use the car. So those logistical barriers, in addition to childcare, oftentimes we don't provide childcare at psychological service centers. So that is a challenge for folks to be able to get there. And also, I think the lack of knowledge about the benefits or potential benefits around psychological services. And then again, going back to another logistical is finances. Sometimes they don't have a lot of resources financially to pay for a course of treatment that's really going to get them to a level where they want to be with their trauma recovery.
But I love that video because um it is, we talk a lot about when we're just speaking about trauma, and even our participant who shared some barriers even in the conversation about treatment. Um I think these are things for us to be aware of, right? Is that we may see a loved one who is experiencing or has experienced trauma, and you're seeing the effects of that trauma, and you're sharing with them, go to therapy. Therapy would be great for you. Go to therapy. There's so much that goes into getting into the room with a therapist. Um, and so supporting, some of the best support we can do is to share with them resources in the area. This is the holiday of giving. And so if you're thinking about, if you've had this conversation with a loved one and maybe they've said, well, I would go, but I don't have the money for Uber there, or I don't have the money for a metro. Give them a gift card that they can use for transportation to their appointment. So there's different ways that we can think about these barriers. And also one of the great things about the pandemic is that it's really opened up the doors to virtual therapy. And so access to care has shifted. And so just something to think about when we're thinking about the barriers to treatment, or even just kind of making that first step.
Dr. Carter,
Yes.
we have a couple questions in the Q&A. Would you like to address them now, or wait a little?
We can address them now before we go
I
into
think they
workshop.
related to some of the slides you've already shared. There was one question here from Vera Can other family members who perhaps witness abuse deny that trauma occurred to a person because of their own trauma regarding being present?
Yes, yes. Because what will happen sometimes is that that individual is, and we're going to talk a little bit about the vicarious trauma. And so that individual can be having their own trauma response to that. And so they want to forget it. So they're working on their, telling their brain this did not happen. And so that then allows them to be able to deal with it. And that may be a result of their own direct trauma.
Mm-hmm. Okay. And then Mary was asking a question regarding, I'm assuming it's the impact of emotional abuse um, on an individual. And she was giving some examples of how just being told that you're a hopeless case or you may not amount to anything and things like that. I think she was wondering about the emotional abuse and the impact of that on an individual.
Absolutely. I think for quite some time, um, there was not a lot of focus or research on emotional abuse because it was something that you couldn't see. We can see physical abuse. A lot of times there are some physical effects to sexual abuse, but we can't see emotional abuse.
Mm-hmm.
But we have research now that tells us that emotional abuse has lasting effects, quite similar, and in some situations, even more intensely or more severely than some of our the abuse experiences where there's a physical effect.
Mm-hmm. And Trista asked, what if there is a combination of these factors secondary to primary trauma and familial trauma over generations? So that sort of intergenerational transmission of trauma.
Yeah.
Any thoughts on?
Absolutely. The cycle of abuse, and I didn't share that here, but there's a whole sect of like work around the cycle of abuse. And that cycle of abuse very much so is generational. And so with that, you hear folks kind of in a sensationalized way, but there's some realness to it. You hear folks talk about being the cycle breaker. um, by making, changes in how you address things with your own loved one, with your own like immediate family members, whether you're a significant other, whether you're a parent, whether you're aunt, whether you're an uncle, a cousin, changing how you interact with those individuals. Also, sometimes it is like being the family member who talks about like, these things happened. I know that they're affecting me. So I'm getting support on addressing those things. Why don't you come with me? Let's do a family session together.
Mhm,
That's also a possibility as well. That can be very vital to breaking that cycle.
mhm. Thank you. I'll get to some more questions in a bit, but I think you'll cover it in your next few slides.
Awesome.
Thank you.
Thank you. Great. So let's talk a little bit about adverse childhood experiences. Um, so some of you may have heard of this referred to as ACEs. And so ACEs are potentially traumatic events that can have negative and lasting effects on an individual's overall health and well-being. And these experiences can be physical, emotional, they can range to divorce and incarceration. And we're going to look at a couple of these here. And so we see abuse here, we see neglect. I want to highlight household challenges. And so we're looking at substance misuse, having chronic mental illness um, can also be related to ACEs here. And then intimate partner violence or domestic violence. There's also some additional adversities related to natural disasters, witnessing or experiencing acts of terrorism. And so highlighting this here, and we're going to talk a little bit about like when the ACEs work first began. We've had at least 2 revisions to the work at this point. And as part of this second revision, the first version of the ACEs work focused in on, I'm going to jump back for a second. The first version of the ACEs work really focused in on abuse and neglect and some of the household challenges here. And the second version of this work is where we really got into looking at the impact of bullying as an adverse childhood experience, food scarcity. And so, for instance, so I am based in the District of Columbia. And here in DC, we're broken into 8 wards. And there is a lot of economic diversity amongst the wards. And as part of that economic diversity, there are some spaces that are considered food deserts. And so individuals have to leave their current area and have to have access to public transportation or drive to another ward in the city in order to access grocery store. And in addition to that, in order to access a grocery store that they can afford. And so this is where we have the space. This is an example of food scarcity. Peer rejection, experiencing racism, poor academic performance are things that were further evaluated in the second version of the ACEs work. And so the way the ACEs work is identified here is looking at 0, 1, 2, 3, and 4 or more. And so this is just a bit of a breakdown. At least 24%, 24.5% of women out of this, there were approximately 9,000 folks in the study. And of that, at least 24, almost 25% of women had experienced at least one adverse childhood experience. And this was evaluated on adults. Men with 27.9% and an overall percentage the 9,000 was women, approximately 8,000 men, but the total was about 17,000 participants. And of that, 26% of those individuals had experienced at least one adverse childhood experience. And so I'm just going to go over this quickly, but initial study in 2012, 2013, started off in Philadelphia looking at about 1,700 Philadelphia residents and considering community level adversity. Now, to note, the original ACEs population, the 17,000 we mentioned, the original population was predominantly white, middle class, and college age. And so research found that almost 7 out of 10 adults had experienced one ACE, and 2 in 5 adults experienced 4 or more ACEs. And these are some of the questions. These are just examples of some of the questions that were part of the study. So the percentage, so I have a couple of pictures here. This kind of breaks this down throughout the country. And this is also looking at, we're looking at ethnic diversity here as well. And so you see the highlighted areas are the spaces where the higher percentage. And so higher percentage of Asian Americans experienced no ACEs. And then looking at one ACE, higher percentage across the country of 30% of individuals who had experienced ACEs. And this is looking at some data from 2018. And then we have 2 or more here. That is a higher across the country higher percentage and Black individuals in the country. at 33%. And so this is, looking at 2 or more. I'm going to stop here for a second. This is looking at 2 or more ACEs just throughout. And then I also like the breakdown here, looking at different regions in the country. So also looking at the relationship between adversity within a family and adversity within a community. And I like sharing this this visual as well, because community can be, or support from a community can actually be a curative factor or protective factor when it comes to adverse childhood experiences. But sometimes it also can be an ACE, or it can also be an ACE within itself, different events in the community. And so this, this kind of visual grew out of the need to really illustrate the relationship between adversity in the family and in the community. And so the kind of leaves on the tree here represent some of the ACEs that we mentioned. And then also looks at the things that are kind of underground here are some of those impacts from the community. And so, this is the idea here is that the tree could be planted in what is described as poor soil. That then can make an individual more susceptible to some of these things that are above ground. And so we see violence in the community, we see community disruption. Again, we're seeing a lot of that, we're seeing a lot of this across the country with the kind of overall push in some spaces, or encouragement in some spaces, of folks moving in to a different areas. So for instance, here in DC, we have a big push of folks moving back into the city and moving out of more suburban areas. And so what that results in is that individuals who have been living in certain areas for generations are now, their community is being disrupted, and they don't have the connections with those individuals that would have said, like, the grandparent that sits on the porch and would say, like, hey, I haven't seen this child walking on the street today, something's going on. And so so this is just a nice visual of that. So just a quick note, we're going to after this in about 5 minutes, we're going to take a break. So just to kind of name that for folks.
Dr. Carter,
Yes.
could we address a couple more questions regarding ACEs before we move on?
Yes, of course.
Make sure they don't get lost. Well, I do want to come back and highlight Kevin's question, because I really want to make sure it doesn't get lost. Are you able to access the Q&A feature?
Would you mind,
I
Mike?
can just, I can just read it. That might be easier. Sure. What are the clinical implications of validating a client's trauma, even if it seems relatively minor to us? For instance, if a client could end up focusing more on recalling negatively valent life events and could begin seeing their symptoms as intractable. I have clients with a lifetime of trauma and precarity, and the mental health system implicitly reinforces focusing on symptoms, and I worry this leads to low self-efficacy.
Yes. So so there's a lot of things that are that are within that question. I think I'm very careful about, as a clinician, I'm very careful about identifying the intensity of a trauma for someone else. Something that may seem a bit smaller, quote unquote, like something that may seem a bit smaller to us can be very large to someone else. And so I think that's the first thing we have to be very careful about, and really allow space for a client to, with your support, to identify that what that trauma means to them. So I think that's the first thing. Secondly, we know that individuals who've experienced trauma are also then susceptible to other traumatic events. And sometimes that is because of their environment. Sometimes that is because of their vulnerability. And so one of the things that we can do is we can help to support them in processing and understanding their triggers, but also to create like spaces where they can evaluate what feels safe for them. So for instance, it may be for a client who is more susceptible to trauma by walking home from work, and they get off of work at 11 o'clock. We can support them in thinking about additional safety measures. Maybe they wait an extra 20 minutes so that they can walk home with a coworker. And so it can be helpful for us to support them in thinking through it in that way. The last thing I think is when you have a client who is expressing trauma in this manner which you're describing, it may be important to take a pause on the current course of treatment, because that may mean that they need trauma-based therapy so that they can really focus in on the trauma, understand how the trauma impacts their life and its totality, and then they'll be able to come back and address those the other experiences that they're having, and other things that may quite possibly be secondary to their trauma.
Great, thank you. And then Mary had a comment was stating that when I took the ACEs training, I was amazed at how much ACE affected physical health issues later in life.
Absolutely, absolutely. And we're going to talk about that. We're going to talk about that actually in just a moment. A little bit more of the health piece there. Absolutely.
And the last one I'd like to highlight before we move on is you had mentioned poor academic performance earlier. And there's a question from Craig. What sort of factors surrounding poor academic performance are indicative of this ACE?
So I've worked with children in the past who, when you can look at their grades in school, and you can almost pinpoint sometimes within a couple of weeks when their trauma started. Because they may have been a successful student, and then all of a sudden they are late to school. They're falling asleep in class. They are being unkind to their peers. They're isolating themselves from their classmates. They're disrupting the environment. They're refusing to complete in-class assignments and complete homework. And so that's just an example of like some of the academic challenges we may see. We also have some research that indicates that when individuals who have unresolved trauma, or children who have unresolved trauma, may be triggered when it comes to standardized testing as well.
And I think that highlights Vera's question. It's a question, but I think you've answered it. And the question was, couldn't poor school performance also be a result of trauma as well as being a source?
Yes.
Thank you.
Yes.
Yeah.
Absolutely.
Okay. All right, we'll pause and I'll let you continue, and then we'll get back to some additional questions later.
So let's do this exercise together, and then we'll take just like a 3-minute stretch, use the bathroom break. So it can be very helpful to think about your own ACEs score. So I'm going to take a moment, again, using that piece of paper, and using the information that you have there. We're going to do a little exercise here. We're using your thing. So let's take a step back. So as part of, I'm going to go back to the original slide, like for you just to write down in your note section or on your piece of paper, write down any ACEs that you have experienced in your life. So I'm just going to go back to our initial slide here where we had some examples. So let's just take a moment. And once you're done, if you feel comfortable, please place in the chat, not the particular ACEs experience, but the number of experiences. So for instance, if you wrote down bullying and neglect, that would be 2. Okay. So we are, so it is important to be aware of your own ACEs experience. And just in an essence of time, we won't do this particular breakout session, but it's important to think about how might knowledge of your own ACEs score affect how you interact with others. And why is it important to be aware of your own ACEs score? So please feel free to share your thoughts in the chat, and maybe we can ask, maybe we can ask one person, can each come off mute and quickly share a response to a question. I saw Mary's hand there. Mary, please.
I recently had a kind of a breakthrough where I came to a realization. I always felt that, PTSD was, a vet or someone who'd had sexual abuse. But I came to the realization that being told you're a hopeless case, my mother hit first and asked questions later. And my coping mechanism for that was isolation. There was a room in the building where I could escape to and with books. And I have discovered that for 70 years, isolation has been my lifestyle. And I just came to this realization recently, and I'm like, okay, if this has been the life pattern, then how do I break out of that when I still, I'm a widow now and I don't have a lot of friends. And since COVID and isolation has gotten even worse, and, how do you break out of that isolation lifestyle?
So yeah, that's a very, and that's a very good, like, good for you for having that, for taking that time to have that realization, right? And so now, one of the, we talked, just kind of, I mentioned this a little bit before, but one of those protective factors could be community. And so, identifying spaces where you could potentially build community. And that could be if there is a community center in your area, or if you're involved in a, in a church or a synagogue, finding community there. Also, another really great thing about the internet now is there's so many ways to find community through different like online groups that are really positive, and that'll be like part of the initial step when it comes to that isolation, and in having this knowledge of your ACEs score too will support that as well. Thank you.
That's oh well and good. It's doing it, and what I noticed on the ACEs score, or maybe I didn't recognize where to fit it, is I didn't see sexual abuse. As
Yes.
I know that I did the ACEs training, and there was a form that had like I think 14 different situations to be able to determine the ACEs score. And what I noticed here was that a lot of the things that were on that form were not in that slide. So I don't feel like I had an accurate ACEs score.
I understand that, and I apologize. I didn't go back to the slide that we had before, that also had the sexual abuse, the physical abuse, that allowed that full space. So yeah, there are about 14 things that are listed there. Thank you for highlighting that, Ms. Mary. So
Thank you.
So why don't we take our break here? So it's 1:08. If we can come back at 1:11, take a quick bathroom and stretch break. Thank you. Sorry. So we're so just sharing a quick example here. As I mentioned, I'm based in the District of Columbia. And so there was a study that was completed that just kind of highlighted the ACEs scores of individuals in DC. And overall, our numbers indicated that children between the ages of 0 to 17 had experienced at least 2 or more ACEs. In particular, things such as neighborhood violence, living with someone who's mentally ill, and having a parent who served jail time, having an individual who's being treated or judged unfairly due to race and ethnicity. So this is just an example of ACEs, children experiencing ACEs across the country. And then just highlighting a subset of that, again, in DC. There's similar studies that have been done in various states throughout the country. Also, I wanted to share this too, because indicating that, I mentioned that one of the most common ACEs here in DC is parental divorce and separation. But one of the most common ACEs nationwide right now is also parental divorce and separation, followed by, a little bit by substance use, substance misuse in a household. So I'm gonna kind of go past some of these slides, but just highlighting again, we talked about 4 or more ACEs here. So let's talk a little bit about, because I know we had a question about health effects. And so we have a couple of examples here of having the reduced ability to respond or learn or just kind of figure things out. Also, a lower tolerance for stress, an increase in problems with learning and memory. And sometimes with its increase, some of the learning difficulties and the memory impact can be permanent. And then we have potential increase and social instances. So being able to make friends and even being able to maintain those relationships that may have been made prior to the adverse childhood experience. And then an increase in stress hormones. And so this goes back to, we were also talking about previously about single incidents as well in comparison to complex trauma. And so some of the kind of health responses with a single incident is having flashbacks, having avoidance, and having been impacted not only by the trauma, but being impacted by attempts to cope with the health effects of trauma. And then in complex trauma, having health problems can be more severe. It result in things like migraines, stomach aches, digestion issues, concerns related to energy. And in adults, we could see sexual difficulties as well. And then also, as part of, in addition to some of the health effects, we could see also income and housing concerns due to the impact on development if the events occurred in younger years, and also due to the loss of opportunities. Okay. And then just a quick look at there's a number of neurobiological effects. We talked a little bit about memory here. And so trauma, memories of trauma can alter the brain. So we have research that has come from autopsies that are done on individuals who experience chronic trauma. And there is a noticeable difference in their brain in comparison to individuals who have not experienced chronic trauma. And so this is something for us to be aware of as well. And then particular parts of the brain that are impacted, we have the amygdala, which is really our emotion center, and experiences various alarms when trauma occurs. Then the hippocampus, which is our memory space in our brain, and it's the part of our brain that moderates our reactions to things. And then we have the prefrontal cortex, which is directly impacted by trauma, along with the amygdala and hippocampus. Okay, so we still have those definitions of trauma and complex trauma and chronic stress and ACEs that are in our brains. So let's talk a little bit about screening for these. Now I want to give a point that we're going to talk about this as well. I want to give a point that some of the screening tools that we're going to talk about are things that are going to be that an individual who has experienced trauma can do for themselves or can be supported in completion. But there are specific screening tools that I am not sharing as part of this presentation because they should be completed by a trained mental health professional. Just have to click real quickly video for this here. I'm just going to watch a snip of this.
Tools that you can use to help you effectively assess for trauma within ethnic minority populations. Obviously, first and foremost, you want to make sure that whatever assessment tools you have, they have been validated on the specific population that you're trying to work with. Additionally, when we're thinking about measures and assessments in terms of translation, direct translations often don't work or may not be appropriate. So again, it goes back to, has this measure, the translated measure, actually been validated with this population? Things to think about are you looking at culture? Are you assessing culturally specific factors? Are you asking about racism and discrimination? Sometimes that's not directly included in trauma measures. They're looking for kind of the big name stuff. But we know from the literature that daily discrimination and lifetime discrimination and racism, as well as historical trauma and immigration status, all can be lead to trauma and symptoms. So it's important that we assess for those in addition to a lot of the other factors. Oftentimes we'll see ethnic minorities presenting not with psychological symptoms, but physical symptoms. So the somatization of symptoms can be very common. And for that reason, we oftentimes won't see ethnic minorities coming into our therapy treatments, our outpatient services. And so they'll be rerouted through their primary care physician, or even more commonly, the ER. So I think that is one really important thing to consider when we're talking about how ethnic minorities present these trauma symptoms, is it may appear as reoccurring headaches, stomach aches, unexplainable pains, and not necessarily thinking about how this might be trauma related.
So I just pause here and move forward, but this information is really helpful because, and I'm pausing here because the rest of the video goes into more specific like assessment and screening techniques for mental health providers. But wanting to just, I like how she highlights here, paying attention to the fact that you may encounter someone who you may be aware that they have experienced a traumatic event, but they are not presenting, they're not saying, yep, I've experienced trauma, or they're not acknowledging the trauma experience that you may be aware of. And so they may have physical symptoms that are indicating that. And so this is also why a lot of times a family member can get someone who's experienced trauma, they can get them to go to their primary care doctor to deal with the back pain that they're experiencing and the lack of sleep, but they can't get them to go directly to a therapist first. So something to be aware of there. Okay, so I have a scenario here for us to have in mind as we're going through. So Teresa is a 25-year-old female who recently graduated from an MBA program. She moved to a new city and started a new job a few months ago that she loves. However, Teresa's boss often makes her feel uncomfortable. He sometimes massages her shoulders while she's working and often compliments her on her clothes and body. Teresa dreads going to work, and even though it is a great job, she is thinking of leaving. Since she began her job, Teresa has stopped going out with her work friends, sleeps a lot on the weekends, and only talks to her sister briefly once a week, though they used to speak daily for at least an hour each night. During a recent doctor's appointment, her physician expressed concern about rapid weight gain. Okay. All right. Let's take a look here. Okay, so common reactions to trauma, we've seen this. So intense and unpredictable feelings, changes to thought and behavior patterns, sensitivity to environmental factors, strains in interpersonal relationships, and stress related to physical symptoms. So we think about observational cues. These are observational cues, are in essence things that you can see. So you may suspect that someone has experienced trauma. These are things that you can see. So an example with behavior could be that individual is not getting along. For instance, if we're thinking about children, that individual is not getting along with their peers in class. They're involved in multiple physical altercations with their peers. A physical example could be you have an individual who really enjoyed exercising and used to get up in the morning and run frequently. And now they refuse to run, they refuse to go to the gym, and they prefer to not participate in any physical activity. Example of observational cues when it comes to hygiene is that individual used to shower every morning before work. And now they will go for days without showering or brushing their teeth. And then an example of cognitive observational cues is individual frequently forgets their keys or loses their wallet, though previously they weren't an individual who lost things. They frequently were able to keep up with their items. So some examples of observational cues, and these are important because these are things that you will be able to observe, you'll be able to see. So let's take a moment. So when we're talking about screening for trauma, we have some examples here of for self-report. Self-report is like that individual completes a screener themselves. So we have some examples of online screening tools. These online screening tools are oftentimes these are self-reports as well. And here's two examples of an online screening tool. So you may have a family member that comes to you and is sitting with you and they're sharing with you that they are experiencing, certain difficulties. And so you may say, hey, like, here's a screener. Why don't you take a moment and complete this? And let's see what our next step should be from here. And then, as I mentioned before, formal screening and assessment should be completed by a qualified mental health professional. Also thinking about engagement here. It is important when you are engaging with someone or maybe asking them or supporting them through completing a screener, that you are being very respectful of their individual experiences. Also, that you are maintaining healthy interpersonal boundaries with them. You don't want to be the individual that every time you see that person, you're saying to them, like, I know you're having a hard time. I know you're experiencing this. And so that's a space of like respecting their boundary. Supporting individuals through minor changes, as well as being consistent, open, and compassionate in your communication. And just overall being aware and respectful of the individual's culture and how that might affect how they perceive trauma, and safety and privacy are also very important. So before we talk a little bit about the post-traumatic growth here, Dr. Coker, Pia, are there any questions? I want to just take a pause. Are there any questions in the chat or in the Q&A that we should address before we move forward here?
Just a few. One was someone wondering about EBPs for screening ACEs, and I added a few there. I don't know if there's others you may want to share, but I added some that we typically use in our practice. Of course, the Adverse Childhood Experiences Questionnaire, the Pediatric ACEs and Related Life Events Screener, the PEARLS, and then the TSCC, the Trauma Symptom Checklist for Children. Those were 3 of the EBPs that we use. So I added those there. Were there any others that come to mind for you that you'd like to share?
The only other one that I would add to that is the UCLA PTSD Index.
Okay.
There should be a DSM-5 revised version. I don't think they've
Mhm.
revised it to the DSM-5 TR yet, but there is a DSM-5 revised version.
Okay. And then there was another question and comment. Are people who have higher ACEs scores more inclined to be in helping professions? It's not always good to be the one likely to help when no is a better response. Vera.
That's a really good question. I would not necessarily say more inclined to be in. We do know from a general sense that individuals who enter the helping profession oftentimes have a different level of like empathy and a number of different like characteristics. But I wouldn't say necessarily they enter individuals who have experienced ACEs at a higher rate from a holistic perspective, that at a higher rate they enter into the helping professions.
Mhm. Okay. All right. Well, you may continue, and we'll pick up some others during the next Q&A period.
Awesome. So we're gonna just talk, I just want to talk briefly about post-traumatic growth. And so post-traumatic growth is a form of positive growth made from seemingly negative and stressful situations in life. And so there can be with post-traumatic growth, this is really a kind of a term that indicates that there really can be some positive psychological change from a traumatic event. Now, this doesn't mean that anyone like there's dismissal of the distress and the adversity and the experiences that come from trauma, but that there can be some positive experiences that come out of potentially addressing a trauma or moving through the symptoms of trauma. And so, post-traumatic growth can also coexist with diagnoses such as PTSD. And some really strong characteristics here. We have that individuals such like so women and adult individuals who are adults at the time of trauma, and those who also naturally have personality traits like openness to experience or extroversion, typically or not typically are more likely to experience post-traumatic growth. And we hear about resilience here, and I'm not going into resilience a lot in this particular presentation because there's a whole section around our whole set of work around resilience and trauma. But just noting here that post-traumatic growth is a step beyond resilience. So let's get into talking about vicarious trauma and secondary traumatic stress. So I have an activity here that we can do together. And so this, and I'm thinking, just looking at time here. I'll share this activity and you all will have, and Dr. Coker-Pia, individuals will have access to these slides, correct? Okay.
Yes, that's correct.
Okay, I will link this activity within the slides. This is something that individuals could do on their, on their own time in essence. And you'll also have my contact information. So if you have additional thoughts after you've completed this activity, please
And
feel free.
Dr. Carter, just for everyone's information, the PDF version of the slides have been added to the chat, so they can go ahead and download now if they'd like.
Okay, I don't think that there's a full description of the life activities exercise. And so what I'll do is I can share that with you all, Dr. Coker-Pia, and you can share that in addition to the slides, if that's okay.
Perfect. Thank you.
So in essence, this activity is really being able to look at making a list of 5 to 10 things that you can realistically do in your lifetime. So places you might see, people you might meet, and ways that you can make a difference. And how this can be really helpful is to really to ground yourself and ensure that that you have plenty of opportunities to encourage yourself and to encourage like others. You could do this with a partner, you could do this with a friend, you could do this with a colleague. I love doing this with colleagues who are doing similar work. And this is a good way. It can also help someone see if they're having their own trauma response. And it can also help someone see understand that this does not their response or their experiences don't have to dictate their future. So thinking about exposure to vicarious trauma. And so a couple of examples that are within our wheel here is this comes from, so vicarious trauma, we're going to talk a little bit about the definitions here, but the response to this could be things such as fear and anger, grandiosity, so an inflated sense of the importance of the work that you're doing, diminished creativity, also a sense that one can never do enough. And vicarious trauma occurs after long-term exposure to traumatic events or traumatic events of others. So let's take another look here, because we love visuals that help us understand this. And so this is with vicarious trauma. When an individual has experienced vicarious trauma, there is a worldview that they may have. And so they may enter a profession with this worldview, the desire to help individuals, the desire to support individuals in moving forward. And then they have been working with individuals who experience extreme homelessness. And they're working with individuals who experience extreme homelessness and a number of other traumatic experiences. And so now there's a change in their worldview. And so there's a possibility of a loss when it comes to connection. The work is intense. And so they're experiencing difficulty connecting with others, feeling safe. Also just being around, physically being present with loved ones. And so what's important as part of the addressing the vicarious trauma and supporting yourself through this work, seeking support through this work, is getting to this future worldview where making meaning of the work that you're doing while continuing to relate to others, while continuing to build personal strengths and developing an overall appreciation of life. And so some indicators here of vicarious trauma. Intrusive thoughts. And so intrusive thoughts are like vivid dreams or nightmares, having flashbacks, and just in some way, persistently like re-experiencing trauma. Excuse me. Also having, so some of the hyperarousal reactions here. And then also experiencing, that's part of our emotional like distress. And so experiencing anger in a very intense way. You may find yourself lashing out at your significant other forgets to take out the trash. And now there are ants in your home because they forgot to take out the trash. And so you lash out at them. because of the intensity that you're experiencing in your work. That empathy fatigue, just being tired of being empathic, and really losing that capacity there. Avoidance behaviors, so just avoiding being with other individuals because then they ask you how you're doing, or they ask you how work's going. Okay. And so we wanting us to look at kind of 4 parts here, looking at vicarious trauma, secondary trauma, compassion fatigue, and burnout. And so with vicarious trauma, as we mentioned, this change in worldview, vicarious trauma comes from repeated exposure. And so this is like working with an individual, a population that has high exposure to chronic trauma. And that's that witnessing trauma over time. And we have secondary trauma. In some research, you will see secondary trauma and vicarious trauma used interchangeably. But I think it's important here to separate these two out. Secondary trauma can come from symptoms, can be similar to symptoms of PTSD without being exposed directly to the trauma. Secondary trauma occurs with a faster onset. And so that means that the individual may be experiencing the symptoms quicker than, for instance, with vicarious trauma, where that is like repeated exposure over time. And then they can lead to misplaced guilt, detachment, and then compassion fatigue. So, well, let me go to burnout before compassion fatigue. Burnout is that feeling of hopelessness and fatigue and overwhelm. This also develops gradually over time. And the compassion fatigue can be a combination of vicarious trauma, burnout, and secondary trauma. And this again develops gradually over time. Individuals may experience burnout first in comparison to in comparison to vicarious trauma and compassion fatigue. So who may be at risk? Any professional who works directly with traumatized children and adults, an individual who is in a position to hear recounting of traumatic experiences. And so this could be someone in ministry. This could be an educator or a school staff member. This could be a mentor. So individuals who might be working directly with people on a regular basis. The potential is greater among women. Potential is greater among individuals who are highly, empathic or empathetic by nature, and then potentially greater among individuals who have unresolved personal trauma. Okay. And then you. So we also have the ABCs of vicarious trauma here. And the ABCs of vicarious trauma are awareness, balance, and connection. And with awareness, we're focusing on developing skills, looking at self-regulation and self-compassion. And the ABCs of vicarious trauma are developed as a way of addressing vicarious trauma. And almost as an instance of like coping for individuals who are exposed. And then balance, having predictable routines, having healthy habits, healthy eating habits, and setting boundaries for yourself as well. And then connection, just creating a space for self-reflection, humor, and laughter. And then this is just a continuum that shows here. Really, the important part of this continuum is, in essence, when the trauma symptoms may begin, and when they're not addressed, this could result in PTSD or symptoms of PTSD. And so a couple of principles here for addressing secondary traumatic stress is having knowledge of risk. And so taking time to educate yourself on supports that might be available for potential exposure and monitoring personal responses, having a sense of well-being. And so in having a sense of well-being, you're really taking time to develop the meaning of your work, the purpose, but also developing self-compassion and having openness to addressing emotions as part of that. And developing limits and optimism related to your efforts, ensuring that you are really setting realistic goals for yourself in relation to also like your boundaries, monitoring personal strengths and vulnerabilities, being aware of your own emotional susceptibility. We oftentimes want to believe that we can handle it all, we can hear it all, but we can't. Active, and then again, active monitoring. So identifying strategies and opportunities there. Having a zone of tolerance where you can continually assess presence of symptoms. And then developing a community of practice. This is part of collaboration. Knowing that you don't have to deal with the exposure and isolation. And then knowing when you need to seek help from a trauma-informed mental health professional for yourself. Some of the best clinicians, some of the best individuals in health supporting work have their own therapist. So breakout time here. So I think we have time for maybe like 3 to 4 minutes of breakout. Here's a second scenario that we have here for Walter. Can we, Dr. Coker or Pia, can we support individuals in a brief breakout session? Or in essence of time, might it be best to do this together as a group?
We should probably do it together as a group so that we
Okay.
can get through and then maybe answer a few questions.
Okay. So let's we can use our chat in the Q&A section here. So as a counselor working with refugees, Walter builds close professional relationships with many people who have survived war and torture. He often finds himself thinking of the horrors they describe and has difficulty sleeping. When he does sleep, Walter is regularly awoken by nightmares. So what is Walter experiencing? You can place some of this in the chat. Is Walter experiencing vicarious trauma? Is he experiencing compassion fatigue? Also, how might Walter personally address what he is experiencing? And then what are some potential symptoms that a loved one might observe? Please feel free to, we can have one person or 1 or 2 folks come off mute, but please feel free to also, Dr. Cooper, if you can share what might be anything that might be in the chat there.
Sorry. So we have a lot of comments, both secondary trauma, compassion fatigue, both, but secondary trauma mainly, burnout, VT, vicarious trauma, PTSD, secondary trauma primarily, but some compassion fatigue as well. Walter needs his own therapist. see his own therapist. Yeah, several comments related to seeking help. Loved ones may notice a change in his mood. Lack of sleep can impact everything. He may be irritable or withdrawn. Another comment about seeking therapy. A lot of secondary trauma, vicarious trauma, seeking therapy, self-care.
Awesome, awesome. He is Walter is definitely experiencing some vicarious trauma here. I would say probably, let's say, and we don't have that information here, but when Walter started initially doing this work, he probably very early on experienced secondary trauma, probably quite quickly. And so let's say Walter's been doing this work for about 3 years now. If he's been doing this work for that period of time, he's quite possibly experiencing vicarious trauma, especially with this point here of how he builds the close professional relationships with individuals. So he is experiencing in a very intimate way. He's experiencing some of the emotions that these survivors are experiencing as well. Okay. Great job. And yes, Walter would benefit from having having therapy, but Walter would also benefit from really building that like community, as we were talking about, that community of practice. And Walter would also likely benefit from really taking time to cultivate, to develop a plan where he's cultivating care for himself. Great work. Great work, guys. Okay, so what can you do? What can you do? You can change, focus on your cognitive here. So really change how you're thinking about things. You can alter your thought process on how you support your individuals who've experienced trauma, professionally and personally. Also, you can make sure that you're caring for yourself physically, and then paying attention to your own sensory responses, taking time to listen to, music and things. Also leaning into mindfulness and spirituality. And then building network and community with interactions with friends and family, and using, having opportunities to be creative and let those creative juices flow. And then just developing strong active listening skills, and ensuring that you're taking care of yourself when it also comes to psychological harm. And supporting in the creation of a culture that acknowledges and normalizes awareness when it comes to vicarious trauma, educating other folks about this as well. And so we talked about how you could have assisted, or is this a space for you to think about how you could have assisted Walter and Teresa? So what I'll leave you with here, and then as something to think about, and ask you to again use your notes section there, and in your paper that's in front of you, and even share in the chat here. The rule of 3. What are 3 things you learned during today's workshop? And of the 3 things you learned, what is one thing you will implement after this workshop? Of those 3 things also, what's one thing that you will share with someone else? And that thing you're going to implement could also be the thing that you share with someone else. And then of those 3 things, what is one thing that you will commit to learning more about? I will leave this, Dr. Kokrapia. I think this is a good time we could take the next few moments and answer any questions. And I know that your team as well has a few closeout spaces here.
Sure. Um, Let me get to some of these questions here. There is a question about ACEs and using healing strategies such as yoga and mindfulness meditation. And Michael shares, I've read somewhere related to ACEs that some ways to heal from that is with yoga and mindfulness meditation. Do you know where that is from, and other research on healing sources that you can share?
Absolutely. That, the mindfulness work is so powerful. And that comes from really like the focus on the cognitive awareness piece, and really being able to develop awareness around memories, and as well as like triggers. The one of the points also as part of that research though is ensuring that yoga and mindfulness are not the only thing that an individual is doing to address trauma, that it is a part, it is incorporated in their overall treatment plan.
Mhm. Exactly. And I just want to highlight the comments that Kevin made in response to that question as well. Um, and then also just wanted to, I think it's important to highlight Mary's comment about the importance of the lived experience of peer support specialists as a valuable asset and component of the workforce. Just want to highlight that. And then, let's see, I thought I saw someone with their hand raised, but now I don't see it. Um, let me see what's here.
There is a hand raised, Dion.
That's actually me. I don't know
That's
if you
it.
can
Go
see
ahead and
me.
ask your question. I can't.
No, I was just curious because I know that there's a lot of studies on the ACEs study, but I recently have been working with some work on the ACEs, the other side of the ACEs pyramid, and it focuses on indigenous communities. So I'm curious to know because I know we have so much work on the work with the ACEs, but then this article is specific to what's on the other side of the ACEs community, focusing on indigenous communities and the use of community care work and practicing, like someone mentioned, right, the meditative practices, but from a strength-based perspective, looking at the pyramid that's specific to wellness, specific to strengths, particularly with our communities of color, right? And so there's so much negativity around the pieces of the ACE, right? And what it's drawing out, we're not looking at the other side of what that would look like in terms of healing practices. So I'm just curious to know if that's some, I'm definitely in the work. And so I'm trying to explore it from my own lens and how I'm attributing that to a lot of the undocumented families that I'm working with, but also indigenous populations. So I did want to bring that, the meditation and a lot of I'm using a lot of indigenous practices such as saging and using a lot of things within that trauma work field and making it trauma informed. But I don't see too many articles or too much research on this. So I would love to connect with you, and I'll put my website and my email because I would love to, just collaborate on those pieces.
Absolutely, absolutely. And Dr. Coker-Pugh, if you could, because I can't see it here, if you could take down Miss and I don't want to mess up your
Urania.
Urania. If you could take down
Yeah.
Urania's information, and I
Sure.
think for you, that would be great. Yes, and thank you so much for bringing that up. There are a lot of, and I share the ACEs information because it is really been a starting factor to us really recognizing that there needs to be additional support in these areas, but there's still a lot of work that is being done around ACEs. And it is really amazing to see. I've seen some initial like published work, like dissertations and things of that nature around the holistic treatment and really looking at it from not just using the standardized treatment protocols that we have. And so I thank you for bringing that up because that is so important
Yeah, I've done it like I know we talked about the intergenerational trauma, so a lot of the work that I've been focusing on has been directly on, reflective and clinical supervision from an anti-racism lens using Dr. Ken Hardy's work, Dr. Jennifer Mullen's work on decolonizing therapy. And so I think those pieces are something that is essential in this type of work, particularly when we are working with all these populations and the amount of PTSD and trauma that's out there. So how do we become clinically and trauma sound, right? Culturally responsive. But thank you so much. This was so helpful.
Absolutely. Thank you. Thank you.
And thank you all for joining us today. And Dr. Carter, thank you for a wonderful training session. It was very informative and engaging. You're getting a lot of comments in the chat. I hope you can take a look at it, or I'll save the chat for you. But thank you so much for joining us. And I'd like to also share that we have our next training session on January 23rd. There will be a follow-up of this focus on trauma. It's trauma-informed practice in integrated settings. I hope to see all of you there. It'll be from 10:30 to 12 Pacific time. And I also want to shout out that there's a podcast available called Breaking the Cycle: Communities Combating Adverse Childhood Events. It's available, and we'll drop that link in the chat for you to access. But again, as I mentioned earlier, you will receive a certificate of completion. You'll receive the slides and the recording and resources after this session concludes. Next slide. And please, please, please complete the survey. It's really important for us to have your feedback so that we can learn how to better tailor these sessions and trainings for you in the future, and to continue to bring you this great work free of charge. So please complete the survey that you will receive upon the conclusion of this session. And you also receive your continuing education certificate upon completion of that survey. Next slide. Please stay connected with us. Here are multiple ways to connect. We would love to hear from you. Any questions or comments, or just join our offerings. We love to interact with you all. Next slide.
I put my email in the chat if anything, Ms. Dion.
I have it. I have it,
Thank you so
Urania.
much.
Thank you. And thank you all again for joining. Happy holidays, and we look forward to seeing you in January.
Thank you.
Take care.